Well, good afternoon, everyone. This is Marcy Gallagher with Mountain Pacific Quality Health. It's 1 o'clock, and I think we have a full topic for discussion today. So we are going to get started. Welcome, everyone, and thank you, Todd, for your willingness to present today. Lots going on, lots of changes. So this call is being recorded. So again, please just make sure you put your phones on mute. And if you are on the Zoom call, there's a little microphone next to your name. You can mute and unmute yourself. The call is scheduled for an hour. There is a national nursing home call at 2 o'clock on managing staffing challenges. So I wanted to make sure folks can jump on to that call at 2 o'clock and realize that we may not get through all the questions. So just encourage you to use the chat function, and we can get those questions to Todd if they're not answered during the meeting. So I think that is all for logistics. I am going to go ahead and turn it over to you, Todd, to get started. Thank you.
All right, thank you, Marcy. Can you hear me?
I can hear you.
Okay. Well, before I get started with this, I wanted to let you know that we're still waiting for some pretty good, or at least some guidance from the governor's office to show how we're supposed to do this visitation, not only us, but you as well. So there is some of this that I won't have answers to today, but again, in interest of sharing what we do know, I went forward with this just to give you, the information we could to help you a little bit through this process, because I know it's pretty challenging right now.
On the form they sent, it has Dr. Trevino, so it never had that.
Background noise, someone talking about a doctor. If you can please mute your line. And Mary Argonis, I don't know if you can go ahead and mute all the lines but Todd. Maybe that might help.
Let me try again.
Okay, thank you, Mary. Okay, go ahead, Todd. Sorry.
Okay, thank you. Anyhow, getting back to it, first of all, I wanted to say thank you for doing the efforts you have already with infection control, with nursing homes throughout the state. It's obviously shown that you've done a good job. We've had pretty minimal amounts of COVID-19 in the facilities, so we're applauding you guys for the hard efforts you're doing every day with this challenging infection out there. So hang in there and keep doing the great work you're doing. With that being said, I wanted to go over our team commitments. Obviously, for us, public protection is one of the key elements that we look at, or commitments that we have. Communication is the second one. That, again, that's why I'm presenting today, is to communicate what we know and what we don't know as well, just so you know where we're at, and if we can help at all, let us know. Trying to be consistent on every survey we do. We do have processes to challenge our consistency, the IDR process, and I encourage you to use that. It's certainly something we learned from, and we changed the way we do our survey and our process at times based on that. So keep that in mind as well. We do try to maintain good, accurate reporting of what occurred at the facility at the time when we're on site. So again, that's another place you can challenge us as far as IDR, if informal dispute resolution, if you think we're not doing that or meeting that criteria or commitment that we have. And then the last one is continuous education, which in this time we seem to really be all learning on our feet as we go here. It's a very challenging time, so anything that you have questions on, please let us know, and we'll work on providing guidance and giving you the information we can. So some of the COVID-19 updates that I wanted to talk about today, these are the references that I've used really to develop this response to questions that you all sent into Mountain Pacific and Marcy. So the CMS memo, QSO memo 20-30. I did attach them, I think, in the email that was sent out to all of you, so you should have a copy of these. If you don't, you can always drop me an email and I'll get you directly what we were looking at. The second one is QSO memo 20-31, which really kind of opened it up for, you know, kind of the phases for, no, not 31, excuse me. 31 talks about more about our survey process and the focus surveys and everything. So, so it's focused on those. The QSO 2030 talks more about or speaks specifically to those nursing home reopening recommendations for state and local officials. So really the first time I've seen recommendations from CMS to us in this kind of format. And I understand why they did it in some sense, but in other ways it's frustrating as well for you, I know, and for us as well too. But it does show, you know, just the different challenges maybe even communities throughout the state are having, specific communities versus some that are having no challenges with COVID-19 or limited. So it's, and states beyond that, if some states are far worse than we are by any means. So not that that's a great thing, but it's certainly in a better position for us than where we could be. The third item I have is Governor Bullock's directive on visitation that he issued on June 25th, 2020. And again, that was attached, so I'll refer to that as well. There's some CMS frequently asked questions on nursing home visitation that they sent out. Again, I'll refer to that. It's just dated June 23rd, 2020. There's really no, it's just a, let's see, 4-page document, no real cover page, just starts into frequently asked questions, starts with number 1, of course, and goes through that. So we'll talk a little bit about those as well. And then the last one is just came out this morning is an update to QSO 20-28 nursing home. And I think your slides may be wrong. I just noticed this when I was getting ready for this. I had 31 on this one and it should be 28. So there was, again, it was revised and issued today, 7/9/2020. So I draw your attention to that as well. Primarily what that change was is it was dealing with the access to ombudsman in nursing home facilities. So they did add some, I don't know if it's clarification, but they did add some wordage about the requirement to allow the ombudsman in the facilities if, let's see, what does it say? To residents during any portion of the public health emergency, they should be allowed to come in to have direct access. I do think it tells you in here, though, excuse me for just a sec here. This just came in today, so I'm trying to digest it as well. I do believe it still, you know, kind of requires you to screen folks regardless based on your COVID-19 infection rates in the facility, in your community, et cetera. So, but it is added here, and I just present it to you today to let you look at it and to know what's out there. So let me go on to the first question I had was on visitor restrictions. Can outdoor visitations occur with residents and families, especially with low to no prevalence of cases in the county? No cases in 40 plus days. So some of these questions came in earlier in June before we had a lot of this guidance. So I think some of this was answered. CMS did, again, in their frequently asked questions, and let me read that section of it. It talks a little bit about can facilities use creative means such as outside visits to begin to allow for visitations with CMS and CDC guidelines even before reaching phase 3. So this addresses it, and it does say yes, that they can do that. It does talk about screening of visitors, wearing a face mask, hand hygiene, social distancing, and recommendation of limitation of visitors as they come in. So, and for example, they give an example given here is 2 visitors for 1 resident visit. So again, that's something they did. CMS provided guidance on and does allow that outdoor visitation. And it talks about it being in courtyards or patios or even parking lots. I'm not sure what the governor's emergency rule that he's producing right now or they're putting together to generate for visitation, how that's going to impact this. So I would stay tuned to that. As soon as we get any additional information from the governor's office and direction, we will certainly share that with Marcy and all the other. And I certainly have still, and I've tried to send out things through a listing of the administrators we have on record. So that's important to keep us up to date with your current email addresses and things. So we'll send them out as soon as we get them. So with that being said, that is allowed, that CMS has stated it is okay. Again, I caution you with what the governor has come up with as far as guidance for us. And I think it was on July 7th, just this week. And I will refer to that to you here in another question, to watch what that requirement may override on this portion of it. So the next one was potential steps for reopening. If a facility is not participating in the surveillance monitoring of residents and staff, will that affect their ability to reopen? And the answer to that is, again, because of the governor's emergency rule proposal that he has, and folks are working on as we speak, it's not complete as of today, as of of this presentation. I did include the press conference that he had July 7th, 2020 that mentioned it, and that's the best information I have at that point. But I believe in that, and well, I know in that presentation he does say that testing is going to be part of the ability to allow visitation in facilities, nursing home and assisted living as well. So you want to pay attention to that as it comes out, and again, we'll share that with you. I know they're working. Yeah, go ahead.
I'm sorry, this is Marcy. I just wanted to bring one question to your attention that is in chat, and Rose is asking if QAD is involved in developing the emergency rule.
We are not at this point. From my standpoint, I'm not, but as they present it to us, we will certainly, provide comment and whatnot for it. So I have not been intimately involved with it at this point, no. Okay, any other questions?
Do you want me to go ahead and just ask another question that's in chat, Todd, or would you rather wait to get through the presentation?
No, that's fine, whatever
okay.
is out there.
Yeah, this is, so we do have a question that a facility did reach out to the local ombudsman, and they indicated that they were still awaiting further guidance and did not plan on visiting the facility at this time. But it looks like that this guidance just came out, today on the 9th about the ombudsman. So.
Well, and there is, I'm sorry, there is always the option. There is always the option of, the video or Skype or whatever, Zoom, to do that, to allow for the residents to communicate with the ombudsman's program. So that's still encouraged by CMS and as well by the governor's office, as far as I know. So, that's still there. And if if a resident does want to reach out to the ombudsman's office, they certainly can go that route as well.
That's a great point. And then are outdoor visits allowed prior to weekly testing of staff being implemented?
That's a great question. And I would caution you in the sense that in the midst of of the guidance that CMS has provided, I know the governor stated that visitations are going to require testing of staff and residents. So that's part of what he's, his group is working on. So, again, it's a hard one to answer at this point. I don't know what their final statements are going to be on that layout from the governor's office. But once we do, we can make a better call on that at that point.
Okay, and just one more question about the mandatory testing. Do you know if that includes the critical access hospitals, or is that just for assisted living and skilled nursing facilities?
It says in the governor's statements, it talks about, I can't remember where it says it here. It says senior, what do they call it? The words are, it says something about senior living, I believe, and assisted living, or I can't remember the terminology, but it does address it. We've got to have some kind of clarification for, here it is, senior and assisted living facilities. Does that apply to swing bed residents in the critical access hospital, for example? We don't have a direct answer for that at this point, but we are in the process of getting that answer from the powers that be. So are these guidelines a good idea for, care of residents in a CAW, the swing bed program? Absolutely. Yeah, if you've got to limit that visitation until you're confident about your, your COVID status in the facility, yes, then I would limit it. That's the better way to go at this point, especially with the increase we've had in the state. As you all have seen, I'm not telling you anything you don't know, but we've seen an increase throughout the state in different counties, and some counties that really had minimal as well are included in that. So to me, I would err on the side of caution with those folks and following, the guidelines as well for CDC and CMS. CMS didn't even address the swing bed programs either in our state, or in any state for that matter. So many of these, and I think we've pointed this out in the past, many of these directions or guidance that CMS has issued, they will include the QSO memos and I'll go back to those in the beginning. Sometimes they're just for a nursing home. Sometimes they're for all provider types. If it was for critical access, they would put like 2031 CAW, 2031, whether it be a transplant center or whatever. So that's one of the guides we use all the time to kind of interpret these as we get them. 2028, again, you'll see is nursing home. So we're not getting a whole lot of direction from swing bed, but we'll push forward and get some kind of guidance and share it with you all. Any other questions, Marcy, at this point?
Let's just take one more and then I'll let you move on. Reopening guidelines require weekly testing of all staff. We are hearing staff and residents in the governor's statement. Will residents need to be tested weekly too? Any thoughts on that?
Yeah, again, without seeing what the plan is at this point, I really can't address it specifically, but if you look at, for example, which one is it here? The 20-30 nursing home, it does talk about visitation almost immediately on page 2 of that document. And it talks about factors that should inform decisions about relaxing restrictions in nursing homes, including, the case status in the community, case status in the nursing home itself, adequate staffing, access to adequate testing is one of the items as well. Well, what does that mean? Then it talks about having a testing plan in place based on contingencies informed by the Centers for Disease Control. And then at minimum, it talks about here are the things that should be in that component. The capacity for all nursing home residents to receive a single baseline COVID-19 test. And it goes on a little bit more on that. The capacity for all nursing home staff, including volunteers and vendors who are in the facility on a weekly basis, to receive a single baseline COVID-19 test, with retesting of all staff continuing every week. And then it says, note, state and local leaders may adjust the requirement for weekly testing of staff based on data about the circulation of the virus in their community. So right now, I know, for example, Yellowstone County has a lot of cases of COVID-19, and there have been some in the nursing facilities, as well as we know there's one in the assisted living facility that's been in the news that has had almost 80 to 90% of their residents infected. So with COVID-19. So that's going to have a key component in it, whether they'll be required to have a weekly testing of their staff as well. So again, it depends on what the governor comes out with and his team. Once we see that, we'll certainly let you all know. And then it goes on to say written screening protocols for all staff, each shift, each resident daily, and all persons entering the facility, such as vendors, volunteers, and visitors.
And
So
that
again,
is
screening.
saying, Todd, that is saying all staff and not a percentage, correct?
Correct. And that, again, this is the 20-30- nursing home issued May 18th, which the governor in his directive did reference this. So, and he includes that as a reference. So again, this has given us the guidelines to at least start with what's anticipated to be coming. And then it talks about arrangement with laboratories to process tests. That's the other thing. I think there's a question that somebody had already asked is how quickly will they be able to turn these around and get the results back to you all on a weekly basis. So again, that's another question I don't know at this time how to answer that, to see how many labs are going to be involved, et cetera. So we'll get to that. The last item that's on here talks about procedure for addressing residents or staff that decline or are unable to test. And through what the governor had stated in his news, or his conference that he provided July 7th, he's, in my mind, indicating that all staff would have to be tested. So again, I've got to wait to see what he states, and then we can go from there. This continues on then with universal source control. So any residents or visitors wear a face covering or face mask. Talks about access to adequate, having enough PPE for your staff. And then it also talks about local hospital capacity and the ability for local hospital to accept transfer nursing home from nursing homes. So again, Billings, I would imagine it's pretty busy down there with the challenges they're facing with the community overall. So again, these are things you have to consider about opening up for, allowing that visitation to occur and relaxing some of those, strict requirements. So I hope that answers the question as best I can with what information I have. I'm going to go on to this next one, which talks about weekly testing of staff and residents. Again, we kind of discussed this already. Who is responsible to implement, and is it mandatory? Again, as I stated, the governor's press conference that came out July 7th stated that he was making it mandatory. Haven't seen anything formal yet, waiting for it, as you know. And then who is paying for this if it's regulated by the government as a regulation to reopen? Again, I believe that's something they're dealing with, is how either the state's going to pay or the federal government, or who's going to have to pay for the testing. Not sure on that either, but I can tell you that the Sentinel testing that the Department of Public Health has done through the communicable disease and epidemiology folks was sentinel testing that they didn't charge anything for it at this point. So I believe most facilities have gone through that, if not everybody, and they're just waiting for results at this point. So again, I don't know what to expect for testing, but I'm hoping to hear soon. So that's that particular question. When will the state lab be ready to do weekly staff testing? Again, an answer I can't state when they will be ready. It is one of those areas I know they're struggling with or deciding on how we're going to do that, whether there'll be multiple labs, how they're going to process, how they'll get to that point. So again, we're waiting for that rule on these. The next one is weekly COVID-19 testing for staff isolation with, let me make sure I didn't miss something here. I missed my note. Oh, here it is. It's solitary-based precautions, I believe is what that is, for 14 days after admission or readmission or solitude. Is weekly testing going to be a requirement at some point, and if so, how long will we have to implement it? Again, yeah, it is being required for visitations at this point. I don't know what the plan is for how long that'll occur. I would say it's going to be tied to, the infection in the community and all those criteria that we talked about in QSO 20-30 nursing home. Again, there's, 1, 2, 3, 4, 5, 6, 7 that they talk about that are areas that you need to consider before considering opening up. So I'm just not sure what they'll do as far as weekly testing, or is it going to go to bi-monthly, bi-weekly? I just don't know at this point. So then the next question is, will there be other labs? Again, I don't know that at this point, but I know that's part of the challenge of this, is to figure out how they're going to process all these different samples as they come through. So we'll have to wait and see what that next step is. How's it going to be paid for? This is kind of a duplicative of the other one. So far, again, the state government has been paying for the sentinel testing, waiting for a governor's emergency rule again to determine who's going to pay the bill on that, or how it's going to work. So we'll have to wait to see what their final answer is on that. Again, here's another question about the solitude-based precautions for 14 days after admission or readmission. Is there a way to shorten isolation with SBP of new admits and readmits with testing before admit and then 7 days after? I don't believe anything includes anywhere in the CDC or CMS guidance that this is acceptable. Remember that if COVID-19 is identified in your facility, we would automatically be called in to do a review. And I say automatically, so if you've never had it, it's a new onset in your facility. That is one area that we have to come in and do a full survey. So then we'll look at your processes and see how things are going. We'll evaluate, isolation if you have it or you're able to do it. If you're doing it just in rooms, in their own individual room, to make sure they're not, spreading it throughout the facility, those kind of things. So it's difficult to say this is approved or not at this point. The other areas that we may be called in for, there's two criteria that CMS uses, and one of them has a double, an A and a B. And this is, again, I should mention this is in 20-31, so QSO 20-31. It talks about cumulative confirmed cases bed capacity at 10% or greater, or cumulative confirmed plus suspected case bed capacity at 20% or greater, or 10 or more deaths reported due to COVID. So that's the first, if you meet any one of those criteria. The second is to perform on-site surveys within, and I'm sorry, the first one was within 30 days of that. Once we're notified of that kind of, those numbers that meet any of those 10%, 20% or greater, or 10 or more deaths, then we would have to do a survey within 30 days. The second one is perform on-site surveys within 3 to 5 days of identification when you have 3 or more new COVID-19 suspected and confirmed cases in the facility. And this would be based on that National Health Safety Network data you're inputting weekly. Or one confirmed resident case in a facility that was previously COVID-free. So if we have a new onset in a facility with a resident, and it does say resident case in this situation that was previously COVID-free, then we would have to come out and survey and evaluate. And what that would amount to is focus on the targeted infection control survey process that we're using currently now. So, so are there any other questions that I can answer right now, Marcy?
Yeah, let me just back up. I just want to make sure you address this one about, I think we might have if staff members or residents refuse testing, is visitation in the facility to stop?
I would say at this point, yes, it would, based on what the governor has stated so far. Again, we need to see what his emergency rule will state, and I would hope it addresses that particular issue. I have forwarded these questions on to the department, so they do have them, and they're looking at them as well. So, you know, certainly your questions are well taken, and they need to be answered, and we'll include them in that, you know, that process as we can. So, so anyhow, that's the best I can do at this point as far as an answer for that.
Okay, thanks, Todd. Just a couple more, a clarification question, I guess, on the all staff or percentage on testing. That was in relation to the weekly testing. So again, would that weekly testing be all staff are tested each week, or a percentage?
You know, the way that's a great question, because I had to look that up. It does state all staff and all residents. So initially that would have to occur, and I can't remember, I think it's further on in here, one of the questions that I addressed. Yeah, it's under QSO 20-26. So, yeah, it specifically does state staff and or residents.
Okay. And then just one question, and I'll let you, were you going to say something additional, Todd? Sorry.
No, you're good. Go ahead.
Okay. So if a resident has had 1 and or 2 negative tests, can we let them out of isolation before the 14 days?
I think you need to work with your local folks and epidemiologists too to let you to address that. If they're coming from if they're new admits, I think that's a different story. As far as, you know, the 14-day isolation. Again, I think that has to be established through the governor's direction, or his task force, I should say, to deal with that if they'll allow it. The other thing that's kind of confusing about this as well, CMS states that isolation, you know, if you can put them in a wing or whatever, or an area of the facility that can be somewhat secluded away from other residents, that's if it's available. They don't demand it, but at a minimum, you'd have to isolate them to their room to minimize the spread of that infection. And that would go true, that would fall true for anything that's like flu or norovirus or anything like that.
I don't know, Erica Arajos, are you on? I don't know if you would want to lend any comment or thoughts to that question.
Marcy, this is Pam Webb. I'm on the call. I think Erica was going to come on later.
Okay, perfect.
So can you repeat the question?
Yeah, this was about the testing. If a resident has had 1 and/or 2 negative tests, can they let them out of isolation before the 14 days isolation?
And I would think that the answer would be no. If you think about it, when you're testing, you're only testing for the result for that day. And if there is an incubation period, so if they're in isolation or quarantine because they've had an exposure or whatnot, you wanna wait that 14 days because they could be developing symptoms. So you wanna make sure that you've followed that 14 days.
Thanks, Pam. And then if they do let them out, so the suggestion is to obviously, or guidance not to let them out with the negative test even before the 14 days. Would that be something they would be cited for if they do let them out before at like day 8 due to 2 negative tests? Todd.
I believe that is one of the things we do look at. You know, look at our checklist. I think it's on there, but I don't know right offhand. Look at the criteria that the surveyors are reviewing. And I think, let me look here real quick. I believe it addresses it in that checklist. And this is under 20-20, QSO 20-20, the checklist first appears. They do revise it a little later, but they're adding the reporting and the sharing with anybody that's in a family. The other one, let me get it here. It is 20-29. So the one that they just, no, 20-29 is the other one you want to look at. And I think it talks about, let's look here real quick. It talks about isolating residents that are known or suspected of COVID in a private room, if available, or taking other cautions based on national CDC example, state or local public health authority recommendations. I don't know if one of my surveyors are on the phone that could answer that question.
This is Pam again, and just wanted to clarify. You know, it depends on how you're asking the question and why you're asking the question. If this has been somebody that had an exposure and they had 2 negative tests, but they're still in quarantine for 14 days, I would not take them out of isolation. If this was somebody who had COVID-19 and now they have improvements and they've had 2 negative tests, and I think the tests have to be obtained at least 24 or 48 hours apart. I can't remember. And they're improving. They're not on any fever reducing drugs. Then I think you could take the person out of isolation because they had the disease and now they're better. But if it's somebody who had an exposure, you know, you have to wait that incubation period. That's the reason why there's 14 days. So with asking questions about testing and when can we let them out of isolation, you know, think about what it is you're asking, why you're asking the question. Is it for an exposure or is it for someone who's actually sick? There's, you know, it gets a little confusing, but you just have to think about why you're doing the test. And that could help lead you to make your decisions. Absolutely check with your local health department. And then Todd and his team can you know, it would be up to them. I would think they would probably be asking similar questions. I don't know, but, you know, why are we being the test? Why are we doing the test? So it seems like it should be black and white, and it is, but it's dependent upon what you're asking and how you're asking that question and for what specific scenario.
And Pam, just the clarification that I got that, so they do not have it for, you know, COVID for the 2 negative tests, no exposure, and they have not been positive. So that's the information I'm getting. And then the
So
other,
is this
go ahead,
somebody,
Pam.
no, go ahead. I was just saying, is this somebody that, I mean, if you're doing testing, your surveillance testing, and they've been negative, why would they be in isolation or quarantine? So something's not quite, we could talk about it offline.
Okay. That sounds good. And then do you know if there's a decision tree tool to help with some of these questions? Or maybe we could develop one? Pam, do you know of anything out there or?
Yeah, it's in the CDC guidelines, and we can certainly send those out again. Just that section, not all of it, but there is a frequently asked question that answers those questions. So we can send that out.
Thanks, Pam. Perfect.
All right, thank you, Pam. Going on to the last, I think this is the last question I had come into it. Maybe there's one more, but how frequently, again, weekly, biweekly, monthly, do residents and staff have to be tested in order to reopen? Or do they just need the capacity to test weekly or some other time frame? I don't know that yet. I would say weekly is a minimum for initial until you are able to show no positives in your facility, those kind of things. So again, we'll wait and see what we get as far as guidance on testing and how frequent it'll be. The other question I have, or the next one I had, is reopening of nursing homes. Cases are still rising and we're getting 20 to 50 a day. We are reopening our facilities when it doesn't seem safe for our high-risk population. I can't disagree with that. But what I would say is, again, CMS highlights in their quick QSO, it's not a QSO, excuse me, it's a FAQ, and their QSO memo. They issued one on 6/23, and it talks about that in example 5. And again, I attached that to what I emailed to everyone. And again, it kind of goes over those same topics. If you look at QSO 20-30 NH, it goes over the same criteria. Talks about the case status in the surrounding community, case status in nursing homes themselves, staffing levels, the access to adequate testing for the residents and staff, PPE, and then again the local hospital capacity. So it references that in the frequently asked questions, and it also talks about it. One thing I don't see in here that they don't mention, and I didn't add it here, is universal source control too, is having the residents and visitors wear a cloth face covering or face mask. And then it talks about if they're unable to wear, or unwilling to do. So again, these are going to be pretty key elements, and I can't stress enough, if you're in an area such as Yellowstone County right now, where there is so many cases going on, you want to make sure you're following these guidelines. And number one is looking at your surrounding community, and then your nursing home as well, to see what you have inside there, and then decide from there with the rest of these criteria as far as control of the COVID in your facility. So we're going to look for that. I mean, again, you're reporting to us if you get a COVID positive case, it's going to go on that national database. We're going to, there will be directed at some point to come in and review the facility. or, it may be a little bit delayed, but that's the kind of things that they're trying to have us do and follow up with targeted infection control surveys. So then the last, I believe this is the last one, visitation. Is there an exact plan for visitation to occur? How many can visit? There is nothing that I have found exact that spells it out exactly what you should do. I think many folks throughout the country have facility owners and facility administration and staff have done different things as far as the outside visits. They have done different things as far as how they can accommodate visitation without being electronic or whatever. But the governor's directive has adopted the guidance, this 20-30 NH that I keep referring to. So his directive that he issued, and again, I attached it in here. I think it's the one dated, yeah, here it is. It's dated June 25th, 2020. Again, he directed, or he has adopted that guidance and suggests that. The other part that I did see that talks a little bit about it is CMS frequently asked questions. It references 2 visitors. So you want to look at that as well on how to conduct those outside visits once you figure out the testing portion of it, of course, and what's required to do that. The other thing is the governor's directive of June 25th, 2020 does talk about visitation should be conducted in accordance with the strict screening, physical distancing, sanitation, hygiene, and other infection control protocols set forth in the CMS and CDC guidance applicable to nursing homes. Before permitting visitation, facilities should review the applicable CDC and CMS guidance, ensure that they are able to follow the recommendations contained therein. So again, once he's referring on to 20-30, I think in 20-30 they give you, in phase 2 where we're at, what the requirements are. And so it talks pretty specifically about restricting the group activities. It talks about, oops, excuse me, reading the wrong section. So going to phase 2, visiting generally prohibited. Allowing entry of limited number of non-essential healthcare professional personnel, contractors, etc. So it goes through a list of bulleted points here. 100% screening of all persons, 100% screening of at least the residents, at least daily for all residents. And it describes what that means as far as temperature checks and observations for signs or symptoms. It does also include testing all staff weekly, again, here for visitation. So, again, the governor has stated these are the guidelines that are out there, and they've accepted it. The one thing he's going to kind of push for it is the testing of all residents and staff. So just to keep the infection down in long-term care facilities and as well in assisted living. So let's see. I think that's the last one I had that came in. Marcy, I don't know if there's others that I can answer.
That is all we received, Todd, via the Survey Monkey. We do have a couple additional questions in chat it looks like we have a few minutes.
Sure.
Okay, I guess I'm kind of interested now in, I don't know that we had any of your surveyors chime on. This goes back again to the isolation question. I'm just trying to,
Hey, Marcy, I'm here if you want me to answer that. This is Eric.
yeah, I just wanted to clarify, one of the questions in the chat was the local health department is saying that they can let them out of isolation with the 2 negative tests before the 14 days, but health department is saying the surveyors are going to cite them for that.
So there is a difference between isolation versus quarantine. Quarantine is applicable to close contacts. Quarantine is the 14-day quarantine period. Day 0 is the last day of exposure, and then we calculate 14 days from there. That means they have been identified as a close contact. Isolation, on the other hand, is a confirmed case of COVID-19. If you are placed on isolation and you are a healthcare worker, it is up to your local public health, as they have the jurisdiction, to decide which return to work criteria the healthcare workers have to follow. If it is the test-based strategy, and this is once again for confirmed cases of healthcare workers, you do have to have the 2 negative tests at least 24 hours apart, in addition to improvement in respiratory symptoms and no longer having a fever. So there are 2 different categories individuals can fall under, and we have to follow then either quarantine versus isolation.
Okay, thanks, Erica. What about in the case of like a new admit or a hospital return with 2 negatives who are being cited because of the 14 days or coming from the hospital?
What CDC recommends, and Todd, of course, you can add on to kind of what your guys' CMS rules are, but what CDC says is for a new admission, it is recommended that they be quarantined for 14 days. A negative test during that 14-day quarantine period does not necessarily mean that the individual is not incubating the virus. Therefore, even if you test, say, on day 1, day 6, and those are negative, it does not mean that individual will not become positive. And that is why we focus on the 14-day admission for new admissions or readmissions, that 14-day quarantine period. And I can say, working with facilities and working outbreaks, that has really, really helped minimize the number of exposures and contacts related to a case because the new admissions were placed on that 14-day quarantine.
So that's based, the 14 days, this is Pam Webb again. The 14 days is based on that, what they think the incubation period is. So from the time that you have an exposure to the time you may become symptomatic. That's why if you're testing negative in between any days in between day 0 and day 14, you still might be developing the infection. So you have, that's where that comes from. And just 2 things I want to, in the chat box, I put in 2 different CDC references. The first one is for nursing homes and testing, and it does talk about the different, or why you're testing, and then what, you know, how to follow that algorithm based on why you're testing. The second one I just found, and it's really helpful, and it talks about the time for quarantine. So it goes further, it's a visual, if you like visual, just as Erica just explained it. You'll see it visually because they have it mapped out on a calendar. This person had an exposure here and then had another exposure here, and this is how long they need to be in isolation. So I just wanted to share that with you because I think it would be helpful.
Thanks so much, Pam and Erica. And then Todd, do you want to just mention your last comment in chat about your worksheet?
I'm sorry?
Oh, this okay, this might not be you, Todd. I think several folks from the surveyors are using your login. So it says, yes, 14 days needs to be followed at the least. Our worksheet requires us to look at how residents are protected through the facility IC plan, and TBP use is appropriate.
Oh, okay.
Those links are very helpful, Pam. I will shoot those out to everybody after the call. And then there's a question, what is your understanding of the CDC guidance for PPE in the quarantine zone with hospital admissions?
Is that for me or Pam or?
Well, anybody wants to take it? Pam or Erica, do you have any thoughts on that?
What CDC says is that if you are treating patients for COVID-19, that all PPE must be worn, which includes gown, gloves, face mask, and eye protection. Face mask needs to be a surgical or N95. A cloth face covering does not count as PPE. When we have a case in a nursing home, CDC actually recommends universal PPE use for all healthcare workers, regardless of symptoms of the residents, just because of asymptomatic spread and that kind of thing. With hospital admissions, you know, if you do have somebody placed on quarantine, you should be wearing all PPE, all recommended PPE for the care of that individual, per CDC. I don't know if Todd, if you or any of the surveyors have any additional information on that.
No, I think, Erica, that's what we would follow. CMS keeps referring us to CDC as well, so.
And Liz has a comment. Liz is one of the surveyors. On our worksheet, it asks us to observe PPE for all activities as all PPE. This is Liz again, and with active, it must be all PPE that would be used for airborne/droplet.
This is Pam. So I've got a question about that for Liz. In terms of, you would use airborne, that means an N95 respirator. That's something that you would use if you're doing an aerosol generating procedure. Otherwise, a mask is sufficient. Oftentimes though, we're encouraging mask and then some sort of face shield to protect, face shield or goggles also to protect the mucous membranes of your eyes as well as your nose and mouth. Erica, do you have anything to say about that?
Nope, you got it. That's what CDC does say. So if you are doing aerosol generating procedures, the N95 is required. Now, if we're looking at exposures, it's really important to look at what was done with the patient as well, just because with aerosol generating procedures, if you're not wearing an N95, we will most likely have to consider you an exposed individual and quarantine for 14 days. So it's really important to understand what PPE you are supposed to be wearing for the specific situation.
But with routine care, you don't need an N95 respirator, which would be used for airborne precautions. And negative airflow, a negative pressure room, you could use a regular room with droplet precautions for someone who has COVID-19. Particularly a lot of the nursing homes don't have negative pressure rooms. So for routine care, I'm asking Liz again, because it's confusing if we say that we would use airborne/droplet. To me, that would mean you'd wear the N95 respirator instead of the face mask, and that person would have to be in a negative pressure room. So I'm just clarifying that droplet precautions is appropriate when there is no aerosol generating procedure being performed. Is that correct, Liz, in terms of being surveyed?
Can you see her chat? She is saying, and for residents that are active until all symptoms are gone, yes, if you do not have an N95 face shield can be used. You do not have N95 face shield can be used. I don't know if you can unmute, Liz, or. Okay, she's saying she tried to unmute and it's not working. We might have to grab Liz offline.
Let's do that and get an answer back that everyone knows.
That sounds good. And just a couple more comments in chat. Just, you know, facilities are just trying to manage the hospital admissions and the 14-day isolation period. Erica and Pam touched on that. And then also Erica had a comment that they're working very hard to get the results back to facilities in a timely fashion, and results should not take as long as the sentinel surveillance results.
Okay.
So it is close to 2 o'clock, and if you do have questions that we didn't address, or I missed getting them to Todd, Pam, or Erica, just go ahead and type them in the chat quickly, and I will go ahead and we'll get those off to Todd, try and get clarification from Liz since she couldn't unmute, so we'll get that topic clarified. And then also just a reminder, Pam and Erica have a weekly infection prevention call at 2 o'clock on Thursdays, and they are have been extremely helpful. So I do shoot those out to the nursing home listserv group, and they do go out through Pam's APIC listserv. So if you haven't been calling into those, I would highly recommend it. There's just lots of good information that they provide. And just again, Todd, thank you for taking your time and chatting with everybody. I know it's frustrating for everyone still having not a finalized executive order on all the information that's come out in the next couple days. So just again, thank you everyone for all your efforts and trying your best to get through this.
Yeah, thank you to Pam and Erica for stepping in today too, and Liz.
Very helpful. All right, thank you everyone. Go ahead, Todd.
Marcy, when we get something, we'll be willing to do another presentation too, once we get something from the governor and we can kind of see where we're at, okay?
Okay, I think that would be helpful.
Okay.
Thank you. All right.
All right, thank you.
Hey, everyone. Thanks so much.
All right, bye-bye.